what about cardiovascular risk? This is why you all came, right? Hey, I hear that causes heart disease. Why would I give a guy testosterone even if he's low? That's horrifying. Well, let me give you just a little sampler. There's two recent studies that came out. Actually, they're not as recent now. They were in 2013, 2014. There was one in 2010. And basically, those three studies is what the 2015 FDA black box warning were based on. Two of those studies were really problematic. There were significant post-publication retractions. One of them misreported the results, saying that there was no difference, when in actuality there was a 50% lower absolute risk of adverse cardiac events in men who were treated with T versus the guys that weren't. I mean, that's a pretty significant screw up. This one got my eye, though. The other study, in its all-male database, had 10% women. How do these things get published? And I mean, if you go and look at my citations, you're going to see the journals these are in and the organizations that published them, and you're going to be appalled. But yeah, it taught me not to read abstracts and conclusions anymore, but to look at methodology when I'm reading these studies. It's humbling. So, what do we know about testosterone deficiency and CV risk moving forward? Those are the two studies that are referenced there that are saying, ooh, don't do it. What we really know is that there's increased mortality, there's increased atherosclerosis, coronary artery disease, worsening carotid intimal scores, which is your first step in atherosclerosis development. You've got more fat mass and impaired glycemic control when testosterone's low. And if that's not enough, there's a bunch of studies. These are older, they're observational, but they're showing things like 50% reduction in all-cause mortality when you treat guys that are deficient. This is talking about TRT. Going on, T therapy reduces cardiovascular risks by reducing fat mass, improving lean body mass, improving glycemic control. You know, we know that guys, once they get type 2 diabetes or metabolic syndrome, have a huge increased risk of getting problems with cardiovascular disease. And in fact, this one large observational study went on to show guys that had the highest risk of MI, actually T therapy was associated with a big reduction in actual MI risk. Testosterone deficiency in cognition is not as clear. We've got some studies that show, and these are older studies now, you need an adequate level of testosterone to avoid symptoms of senility. We've got good data showing that. There's an older study here showing that over 10 years, if you followed men and looked at their baseline testosterone and cognitive and followed them, the guys that had better optimal levels, physiologic levels of T, had less problems with cognitive impairment, whether it be visual, spatial, different working memory, parts of cognition. It was better. And in fact, there are studies, there's good data that shows there is a higher prevalence of testosterone deficiency in people with Alzheimer's disease, and there is evidence that it happens before the onset of dementia. So it raises the question, is there an opportunity for replacing testosterone or optimizing it in some way to help protect the neurons against this devastating scourge? We think possibly, and we think it might work in some of these neuronal cells in the hippocampus where cognition is born. And we know from this study that it can be associated with Alzheimer's disease. In this paper that's quoted here, the guys without Alzheimer's had less of an issue with TD than the ones with it. Again, associative, can't say causation, but it sure gets my attention when I have a guy present with cognitive complaints. I'm checking his testosterone. So, just to put in perspective some of the different levels, you start seeing problems with libido in the low 400s. You got to get a little lower around the mid 300s before you start seeing cardiometabolic disease and mood problems. And it's not until you get into the 230s that you actually have a guy usually coming in with erectile dysfunction. About 19% of guys with ED have associative TD. So it's not by any means the most common disease, with guys with low T. It's obesity, it's dyslipidemia, it's depression, it's diabetes, it's these other things. But this is why they all come in, right? So moving forward with the next objective here, we want to look at signs, symptoms, doing the workup. How do you do the labs? Well, you start with a good history, like any good clinician's going to do, and you want to start with the prenatal exposures. We know that prenatal exposures to BPA can be problematic in mammals with testosterone production after birth. We know that phthalate exposure, in particular, is not only associated with testosterone issues, but congenital phthalate syndrome, which is undescended testicles, hypospadias, and a number of other urologic problems that these kids are being born with. And there's great data basically collaborating, showing if you look at metabolites of phthalates in the urine, you can see these tight associations with endocrine disruption. Finding out when they went through puberty, you don't ask if it was delayed, what had to happen. Did they have to get some kind of help to get through puberty and develop secondary sexual characteristics? What is going on with their past medical history? Do they have any history of major metabolic problems, relationship issues, sexual side effects, problems with mood, cognition? Ask them about cardiometabolic diagnosis. Geez, I'm here because I'm fatigued. Oh, my doc just told me I have pre-diabetes. I don't even know if that's a diagnosis. What do you think? These are all the things you want to be thinking of as a biomarker. I've got to check T. And then, of course, medications down there. Some of the symptoms, again, looking at the International Society's guidelines, low libido, poor morning erections, poor quality of morning erections, really big deal. Most guys, if you've got one question to ask and that's it, do you still have erections spontaneously in the morning? And they say no, that's a big red flag. And it's much more specific than many of these other more generic symptoms like fatigue and cognitive impairment, decreased vitality. These are all important, but you want to think about not just the insulin resistance syndrome symptoms and sexual issues, but look at their cardiometabolic stuff. Do they have hypertension? Do they have dyslipidemia? Do they have one of these autoimmune diseases I rattled off a minute ago? And do they have markers of inflammation off the chart? It's not all periodontal disease. It's not all Lyme and mold. It's not always the case. Sometimes it's gut and elevated lipopolysaccharides. We don't have a lot of time to talk about it in this talk, but we know that there's something called metabolic endotoxemia. And when you have a lot of increase in the gut permeability, lipopolysaccharides from that gram-negative bacteria cell wall leaks across. It elevates systemic levels of TNF-alpha, IL-1 beta, and IL-6. And those bad boys are in that first slide where I showed you inflammatory cytokines inhibiting at the brain, at the testicle directly. They lower T. So there's the connection between gut health and low T. Not only does it lower the androgen production, but those same pro-inflammatory cytokines that can be caused by lipopolysaccharides entering lower sperm production. So now fertility is impacted as well as your androgenization. Great connections to make, and that's the kind of stuff that drew me to this type of medicine. When you get these cool little seemingly trivial bits of information that help you understand, when you pull in the spider web over here, all this stuff's moving. It just makes sense. So, how do I use questionnaires in this assessment? There's something called the ATOM. It's in your toolkit. The toolkit. Toolkit's a wonderful place to go get lost because some really amazingly practical things there. ATOM, androgen deficiency, is what we're looking at with that one. If the questions to 1 or 7 are positive, either one of those, that's a positive questionnaire. The other positive criteria is if any of the other 3, and it can include 1 or 7. If we want to know about sexual health from an erectile point of view, which can be a huge marker, right, for TD, do the SHIM, Sexual Health Inventory for Men, in your toolbox. Scores that are 22 to 25, not a problem. Lower scores, not a good thing in this particular questionnaire. There's your key. And then lastly, you got to know about prostate health, because prostate health is affected by DHT, the active version of testosterone. If there's not enough testosterone around, the prostate gets messed up as well. This questionnaire is regarding lower urinary tract symptoms and prostatic symptoms. Score of 1 to 7 is mild, 8 to 19 is moderate, 20 and above to 30 is severe. And these are things your urologist knows. These are the vocabulary they're going to use, and they're going to really, you'll be able to speak their language. So let's get into a case. This is a real patient of mine. J.H. was a stressed out attorney that came to me, and I actually knew him. It was a friend in the community. And he said, yeah, I hear you do this functional thing, kind of like daring me to get him better. And, he's stressed out. He's a type 2 diabetic. He's on testosterone cream. He's dyslipidemic, just nightmare. He happened to be an attorney that was very successful in the community. He's on statins as well. He never embraced the lifestyle message. And let's be real, there's going to be people in your community that they aren't into it. Their wife kind of twisted their arm to get them in the door, or they're just not bought in. Their therapeutic readiness to change is like a 0. They're still pre-contemplative. And you can talk to them until you're blue in the face, but until you got rapport with a guy like this, you're not going anywhere. Anyway, he decided to go get a bariatric surgeon consultation and ended up having a bypass instead of taking my wonderful functional medicine lifestyle advice. So, what do you think happened? And there's a series of questions. We're not going to have you poll or anything. It's just kind of show of hands. Or you can just internally think what you would do. What do you think happened to this guy's diabetes numbers and his testosterone requirement? He was on insulin and he was on testo cream after his bariatric procedure. As a way to kind of get at this subject, what % of diabetics that undergo bariatric surgery have a reversal of their diabetes after the surgery? You guys think you're going to play it safe and go for 2 or 3? I say we go all in and go for 4, because that's what the data shows. Actually, 95 to 98% within a couple of months, reversal of diabetes. Kind of throws out the whole theory about the pancreas being blown out. Another talk. So, other questions. Intermittent fasting. Okay, now I'm going to reveal a little bit of my bias here. Intermittent fasting, is it as effective at reversing diabetes as bariatric surgery? True or false? I'm hearing a lot of truths. You guys are incredible. This is an overachieving bunch. It is true. There's data to show this. Is intermittent fasting as effective at reversing obesity as bariatric surgery? Oh, well, now, Dr. Holthouse, you are really pushing the limit, because this is where a lot of these guys are going, because they're realizing medical nutrition therapy on weight loss is it's a dismal failure. It's like CPR success rates kind of numbers. It's horrible. So what do you think? What do you think? Yes, no? No studies? 3 is tempting. It's yes. It works as well. So diabetes and obesity reversal. True or false? Intermittent fasting does not improve testosterone. That is false. Bariatric bypass surgery improves testosterone. Yeah, it does it too, for the tune of a lot more money. And side effects. Bariatric bypass surgery, but not intermittent fasting, will improve the insulin sensitivity. That's false. They both do equally. In fact, there's data that shows it might do it a little better with fasting. The case study, coming back to it, at 6 weeks after his bariatric surgery, J.H. was off insulin. Blood sugars were at goal. Okay? A month after surgery, testosterone begins to elevate without me changing a thing, from the 500s where he was baseline to now 900s. His lean muscle hadn't changed on his body comp, and he'd only lost about 15 pounds total. Within 3 months, he's off all testosterone replacement, and he's keeping his T at 500. So he's off insulin now, and he's off testosterone, and he's got normal labs on both those parameters. 4 years later, he's still greater. He's like 600 the last time I looked at his T. So this drives home the point that this is a comorbid disease that deserves your attention, working the nodes of imbalance in the matrix before you go straight to what the radio ads want you to do. Boom, testosterone. Boom, HGH, whatever, the supplement du jour of the day, the moment is. On physical exam, after I get my history, I look for these things. Basically, I'm looking for signs of enlarged breasts on guys. If they've got issues with small testicles, I'm going to show you on the next slide how to do that, which somebody tricked me and snuck this into my deck. No, just kidding. I think I actually agreed to this, but you'll see why I'm alluding to this in a second. Acanthosis nigricans, which is the kind of flat, velvety hyperpigmentation in the skin folds associated with insulin resistance. You'll see this. Why? Because 50% of guys with diabetes have low T. So you're going to start seeing things like that. You're going to see central obesity. Yes, gynecomastia. There it is, the orchidometer. I didn't even know that existed until recently. I think you can order these on Amazon. I'm not kidding. Normal adults, you want to be somewhere in there between 16 to 25, and that's in mils, just for those of you who want to know. It's in SI units. That's important to know because that can have a bearing on the physical examination. You got to examine a lot of prostates to be able to say, oh yeah, that's a 60-gram prostate. Well, same thing's kind of here true, and now you've got this little orchidometer to help you along. So what about testing? Let's get into labs. Serum is the way to go. You heard those of you who went to the lunch, Mark Newman say that's it's where all the studies are. It's got the most validation. The insurance pays for it. Just makes sense. You want to check somewhere in the morning between 7 and 10, preferably fasting. The arbitrary line in the sand is less than 300, and it depends on what study you read. But again, AUA, the experts, said there's really no threshold of normal. So, yeah, this is a guideline. Who gives you a range of 300 to 1100 as normal and expects you to take it seriously? Really? So you've got to look at the whole guy. All right, so you want to repeat it if it's kind of borderline normal on that low end or low. And you got to do it again, though, because if they just had a bad day, insurance isn't going to cover it unless you got 2 total serum Ts that are abnormal or 2 free Ts that are abnormal. You can have a combination. You can have a low free T and a low total T on different days. That's all that matters is that you got an abnormal twice. But if you only have one and you check it again a week later and it's normal now, it doesn't mean that I'm not going to maybe think about treating. I'm certainly going to tell them, though, that their insurance paying for it may be in jeopardy. When you confirm that second test, these are add-on tag-alongs. I look at things like free T, the sex hormone binding globulin, that it is the escort of T, just like with estrogen around the blood. I look at prolactin, LH, FSH, CBC, PSA. I want to know if there's a problem with sex hormone binding globulin. Can I take this total T at face value or not? Because of all those things we learned about, and we're going to learn about in a minute, that affect it. But I also want to know if this second T comes back, I don't want to have to stick them again. Is their PSA a problem? If their PSA is 4, or they got a digital rectal exam that's abnormal, I got a problem. I got to get that worked up before I can put them on T itself. So I need to know if it's safe. I need to know if their hematocrit is, really high. There's a cutoff the Endocrine Society has published, 2018, that says, man, you should have a hematocrit of 48 or less before starting them on testosterone. That came down. That was from the 2010 guidelines to 8 years later to 18. That changed. They got more aggressive on that. So you have to know also, is it primary or secondary? So I'm going to want to know what the LH is, because that matters as to how I approach this person. Are they primary or secondary? So how does T exist in the body? This is very basic, but I'm going to make sure that you guys understand it. It runs around tightly bound to something called sex hormone binding globulin, about 50-60% of it. The other 40% is weakly bound to albumin. And then there's the 2% that's free, that's not bound to anything. And it's the free component that does all the lifting physiologically. When we add those all together, it's supposed to come out to about 100%, and we call that total T. When you just look at the free and that's weakly bound to albumin that has some physiologic efficacy, we call that bioavailable. So that's the three terms you want to remember. Just for historical purposes, some of you might have heard the term of free androgen index. It's trying to get at what is bioavailable versus the total. I just check them. I don't use this. And the Endocrine Society says it really isn't helpful. It hasn't been statistically stood up to the rigors of really showing that it predicts anything. So I don't use the free androgen index. DHEA, total T, and free T, you've got some very rough guides there. Free testosterone is always a calculation. Something called an equilibrium dialysis method is the gold standard. This is basically going to have its own separate reference range depending on the lab that you're using. And that's all I'm going to say about it today. Salivary testing, you heard a little bit about at lunch. It's proposed to reflect cellular hormone levels. Some of the issues with it is it's not fully accepted by our allopathic colleagues and certainly not our endocrinologist friends. There's concerns about interlab methodology and errors, especially that occur with shipping instability, contamination. If you get a little bit of serum in the saliva is going to artificially change your hormone levels. And when you look at the incidence of periodontal disease in people over age 50, it's not an insignificant problem. There's really only one paper, as we heard at lunchtime, that talks about correlating enzymatic testing of saliva with serum. And what do? I use serum. It's where all the data is. It's paid for by insurance, and it's more reliable. So I use serum when I'm diagnosing TD. Again, for historical purposes, 24-hour urine for metabolites, when you want everything, you can, for those patients that you don't want to stick around very long, you can give them an orange jug and say, go home and pee in this for 24 hours, keep it in your fridge so all your family sees it, and then bring it back to the lab after that. So it's great if you want to know everything, but now we've got desiccated urine, and I can get everything really that I want this way. It's newer. You can do it. It's 4 collections on a single day in your own home. It's dried filter paper, so you're basically peeing on this little white thing, and you hang it up to dry 4 times, and then those get sent in and measured. It's like serum, and then it correlates with clinical symptoms, meaning things like LH response. Is your brain seeing what you're giving testosterone-wise? Body composition, your fat mass, is it changing? Well, it actually correlates pretty well, and things like bone density. It's great for looking at dose adjustment and following and monitoring therapy for these scenarios really only, topical, pellets, and injectable, which are the most common ways that we usually give T. It's great at looking at metabolites, and that's really its big advantage over serum. It's the only thing you can really look at using dried urine when you're using oral sublingual troches, because anytime you're putting something in your mouth hormonally, you're swallowing a little bit of that inadvertently, and that gives you big problems with trying to interpret urine. You don't have a blood draw. There's no cold shipping requirement, so that's kind of a nice thing. Validation. We talked a little bit about the daily free cortisol pattern this morning. We're still working on the validation of that piece of it, so saliva is the way to go with cortisol as far as we're concerned now. We do know, though, as far as comparing that big orange jug, 24-hour collection, that these 4 dried urine samples are equivalent. Tells you the same information. It's a little bit more expensive, obviously, than serum, but you don't get any metabolites. If you don't need metabolites, do serum. That's usually where we start.